So a common type of patient that we'll encounter in our outpatient environment is the direct access patient coming in with complaints of hip pain. And oftentimes, the anterior hip pain can be the one that's a little bit more nuanced in regards to differential diagnosis and making sure we have a clear understanding of, is this something that's potentially intra-articular or within the joint, or is this more of a soft tissue superficial type injury? So some things that we need to be mindful of is, what is the demographic of the patient that we're working with? And if we're having somebody that has anterior or anteromedial hip pain, we need to be mindful of, is this individual 18 years old, and are they a field court sport athlete where they're having pain with sprinting and multi-directional work? Or is this one of our adult population, maybe they're in their 40s, 50s, and they've had this kind of slow onset of pain that has been present for several months, maybe even several years, and has just finally hit its tipping point. So things that we really need to be mindful in differential diagnosis is this something more consistent with potentially OA? Is this maybe a labrum or an FAI type presentation? Or is this something as simple as just a hip flexor tendinopathy, or maybe even a proximal adductor irritation? So with these different types of presentations, if it's OA, we should have some sort of mechanism that is more chronic in nature, less traumatic, maybe it's relatively insidious, it's had gradual and progressive onset, and from a range of motion and a clinical presentation standpoint, they may have issues with flexion, adduction, and internal rotation, or maybe just global range of motion limitations. In regards to our individual that has potentially the FAI or the labrum involvement, they may also have issues with flexion, adduction, and internal rotation if it's your typical hip impingement FAI individual. If it's a labrum tear, they could have that presentation, or they could have a variety of presentations depending on where that labrum tear is. If it's anterior, if it's posterior, it's on more of the superior or inferior rim of the acetabulum. But that's where we want to make sure that we are cluing into not only our range of motion testing, but what are our provocative events that brought it on in the first place and continue to consistently agitate this area. And then what does our special testing look like too? And when we're doing a Faber, when we're doing a scour, does any of this start to match up with our other hip labrum pathologies and presentations? If it's more of a soft tissue component, things that come to mind here is ruling out proximal rectus femoris, our psoas, proximal adductors, TFL. And this is something that typically should follow a very contractile tissue pattern, meaning we should be able to actively engage that muscle and produce some sort of influence on the symptoms. We should be able to stretch or lengthen that muscle and have some sort of influence on the symptoms. Activities that they're experiencing discomfort with should be consistent with the motions that the muscle creates and produces. Other things that you can help to differential is just simply palpation. Make sure that we're taking a very precise approach in regards to palpating the soft tissue in the area and asking questions in regards to, how does this feel in regards to the pain that you typically experience? Is it similar in location? Is it similar in quality? Is it similar in intensity? Or is it just a different sensation altogether? And if you factor in their overall movement profile, the mechanism of injury, their age and their demographic, the types of activities that provoke it and alleviate it, combined with the symptom patterning and their palpation reports, then we should be able to create a pretty clear picture of, is this something that's more intra-articular or something more soft tissue in nature? Is this maybe more of an OA or a bony presentation? Is it labral, or is it simply a soft tissue issue?